the first international webinar of Cenacolo Milanese. I'm Rossi, the president of this association. We are an Italian association based in Milan. We are active in this moment on our Facebook page with webinars, lecture like today, with an important speaker like Professor Tomas Linkevicius. Now, I introduce the moderator of this webinar, Dr. Leone Praticò. Welcome, Leone.
Welcome to everybody. Thank you, Vincent. This is still a great occasion, a great opportunity to have with us today one of the biggest names in implant dentistry right now. We are going to discuss and debate one main issue remained unsolved for a very long time. Is it possible to overcome the marginal bone loss that occurs around implants in the short term and also in the long term? That is the 1.5 millimeter of bone resorption after the first year and the other 2.5 millimeter, 2 millimeters, sorry, every next year. So I will make a brief introduction of the speaker. Dr. Tomas Linkevicius received his DDS degree in 2000 in Kaunas University, Lithuania. In 2004, he finished a postgraduate program in prosthodontics in Vilnius University. In 2009, received his PhD degree in Riga, Latvia, with the thesis, The Influence of Mucosal Tissue Thickness on Crestal Bone Stability around Dental Implants, and currently serves as an associate professor at Vilnius University, Lithuania. He is the author of many cited articles in international journals, and I could list many other achievements and awards. In 2019, published his book, Zero Bone Loss Concept. You can see the front cover here in this image. And I think every professional who takes part in the process of the dental implant rehabilitation should have this book. I personally like the way it is laid out. It has 10 chapters on the surgical part, on the surgical steps, and other 10 final chapters on the prosthetic phase, each of one dealing with every single aspect involved in the overall success of the final result. It's extremely useful in the clinical practice, not to mention the wonderful job he made on the iconography. So it is now time to give a huge welcome to Professor Tomas Linkevicius. Good evening, Professor.
Hello, hi. Nice to finally connect and start our lecture. Do you see me okay? Do you hear me okay?
We hear you and we see you okay, I think.
Good.
So I want to steal a joke from our Dr. Ramundo. He's a colleague from our Cenacolo, from our association. He said, it's zero bone losses, it's zero bone loss, it's not zero web problem. So I hope this time we go the way we think it used to be. So,
in one webinar, it was the comment, zero bone loss, zero image, because there was also some problems and people did not see anything. So zero is not always a good number.
Absolutely, absolutely. So because the time is running out, I will ask you one first question to get into the topic, and then we could pass straight away to the lecture. Yeah, I will interrupt you a few times.
Yeah, that's good.
Okay, just to give a chance to our colleagues to make questions. So is that the case that if we want to minimize the biological impact on marginal bone loss, we should gain full control on every step of the treatment plan? And if so, what is the rationale behind this concept?
Yeah, so let me then, you just asked the question and my lecture is answer to that. So let me answer you with my lecture, and because it's a straightforward question. So here I'm gonna present straightforward answer to you, okay?
All right, okay.
Okay, so let's start then. We're gonna discuss like zero bone loss concepts. It's a nice name. It's a ambitious name. Ambitious, I would say. And it's composed of two different parts, as it was mentioned. Surgical part, it's how to develop bone stability, and prosthetic part is how to maintain crestal bone stability. Now, let me start with a simple 2 X-rays. So here we have the same implant is the same. And the only difference between these 2 X-rays is here. A small bone loss, 1.5 millimeter of bone resorption. And I kind of tend to look at this a little bit philosophically, because I'm sure many of you or colleagues you know would say that, look, this is 1.5 millimeter of bone loss is just nothing, you know, it's natural, something like a norm. But when you think about a little bit more and ask the question, which implant you would like to have in your mouth or in your mother's mouth, yeah, probably we would like to have this without any bone loss. So I would say that downplaying this resorption, yeah, maybe it usually stops, maybe it doesn't resorb anymore in some cases, but it doesn't mean that this is not important. Because when we talk about also long-term, I think everybody would agree that this with time looks more dangerous than this. And, you know, if this gets reinfected, so we can, I think, be sure that it will be much more dramatic outcome in this implant, although now bone loss is not continuing compared to this one. So I would say we should not, how to say, downplay this initial bone remodeling, initial bone loss. I think usually people who do not get the understanding why is this happening, they say that this is not important. The minute you understand why it's happening, then of course, I think it's stupid to argue that maybe we would have better implants, a bone like this. Yeah, so where there is no remodeling or no bone loss at all, this looks much more stable. And the idea of zero bone loss concept is actually, of course, not to produce or to say that, look, certain brand of implant is magic implant. You know that it's always will be okay. The idea of zero bone loss concepts is that you can achieve bone stability with the implant you are using. And if you apply the concepts, if you apply the concepts which are here, you can have indeed really good crestal bone stability. For example, here you can see this is actually implants without platinum switching and no conical connection, but we still really have a good bone stability around our implants. Again, the idea is not to, how to say, say that bone loss is normal. We can have the bone stability from the beginning, just from the start of the treatment. I was already introduced, so of course I'm maybe not gonna waste the time to do that, but I will just mention, I think one of the important things is that the research which I'm gonna show, and all, let's say, zero bone loss concept research is based on studies which are made in private practice. So I'm a director of private research center in Vilnius Research Group, and the studies which you're gonna see, they were really made in private practice, which I consider it unique and very efficient. We have a net of clinicians who were working together. That's why we really can produce the data which is there. I'll start my presentation probably maybe to emphasize why do we need science? Because, well, for many clinicians, it looks like, you know, I just want to work clinically. Yeah, I am working and okay, science is for universities, scientists is for professors. Give me the recipe, you know, and I will do this. To illustrate this, I chose just one situation and one example. We all know about case reports which are published in international journals, and this is one of the case reports which is talking about that the use of rubber dam is good for removing 7 remnants. And if you would, there are a lot of users of this technique, which they propose that when you place a abutment, then you put a rubber dam on the abutment, and then this really allows you to reduce semen remnants and be semen remnant free. However, when I looked at all these case reports, they really lack one thing. They are not scientifically proven. This is what we did with our team. We wanted to see how does it really work clinically, and does rubber dam really preclude semen remnants positioning in soft tissues. So we started a clinical study when we used standard abutments with a rubber dam. Then we made screw-retained restoration, but before cementation, we closed it with a composite. The idea is that to preclude semen remnants escaping, and then we cemented, after cementation, cleaned semen remnants, and then we removed this rubber dam, removed the composite. I was able then to put in screwdriver and remove all the restoration from the implant. And this is what we found. So we found no semen remnants in the tissues, while all semen remnants were at the bottom of our abutment and the restoration. So actually, a case report tells you one, but when you research it clinically, like it should be, you see that this method could not always is the best way to reduce semen remnants. That is why the zero bone loss concept is based on this pyramid of evidence, and we try to incorporate controlled studies, non-randomized studies, some even randomized clinical trials, in order that it would not be just, my opinion telling you do like this or do like that. It would be clinically researched and scientifically proven background. Now we have over 33 publications on the topic, and also there is a book which we have put all our knowledge together, and it's published, was published last year. Of course, zero bone loss concept, as we mentioned before, it consists of many things. So we have surgical part and you have prosthetic part. So what we're gonna talk about today is actually the first, only the small amount of the information because of time. And of course, I want you to probably maybe get the grasp what zero bone loss concepts actually is, and to then probably to learn about these concepts in the future as well. Let's start with this X-rays, which we actually kind of, are used to see. When we see, call it, as it called, stable remodeling, when you see the bone loss till the first thread, yeah, and like all the implants look very similar. So I would call it maybe better stable surrendering, because what these implants demonstrate, that clinicians are tend to give up the idea that you can have bone stability from day one. Because one of the reasons is, of course, you have a lot of factors, and like 20 chapters in the book could be 20 factors, or 10 lectures in the online course, 10 different factors. But that's not the case. We can really control all of them. And I think majority of our understanding really comes from this paper, which was published in 1986 by Albrechtsson et al. And they claimed that 1.5 millimeter bone loss is okay if the bone stops, if the bone loss stops, and you are fine. Of course, this is, I think this paper, although it was published so many years ago and times are changing, and we should stop using it as an excuse for those cases when we really can control our bone stability. I would see, and let's say, kind of zero bone loss concept is this, that you can have not bone loss, not 1.5 millimeter of bone loss, but 1.5 millimeter of growth of bone after the delivery and after follow-up. So, and you can see it here, the implant is placed at the level of the bone. 2011, 2018, we see the bone growing around and becoming more mature. So I completely disagree with this Albrechtson et al. Success criteria that bone loss is unavoidable and 1.5 millimeter is not any success. It's just do not understanding the reason why we are losing this. If we would look at, again, crestal bone loss a little bit philosophically, we could say that this is on this X-ray, probably this is one of the first X-rays documented of crestal bone loss from the Brandenburg book. So, and this is the X-ray 14 years after. Of course, we see different kind of implant, everything is different, but what is similar, we're still fighting bone loss. So that's why this topic is so important, and it never precluded to be important. But when you think about that, we did not solve the problem 40 years, already for 40 years. Look how everything has changed, the designs, the surfaces, etc. But we still are in the same position. That's why I used to see around our cases, our group of our researchers, this kind of bone stability. And we can see it with implants with platinum switching and conical connection. We can have it around completely different kind of implants without platinum switching and no conical connection. These are simple implants, but they are placed and restored according to zero bone loss concepts. That's why you can see the bone stability. Before we go a little bit further, let me elaborate a little bit around two different terms I will be using, bone remodeling and bone loss. Why do we need those? First of all, let me tell that bone remodeling and bone loss are different. Actually, the process is similar. It's changes of the bone. However, I would consider bone changes above the implant neck as a bone remodeling and bone changes below the implant neck as bone loss. Because when we place implant subcrestal, like here, you can see you have bone above the implant neck and also bone below the implant neck. So we must kind of describe those, because this implant, you can see after the healing, we see remodeling of the bone. So the bone disappeared above the neck of the implant. However, there is no bone loss. So no bone loss here, but bone remodeling. If I'm seeing X-ray like this, so this X-ray, this implant has no remodeling and no bone loss. That's why, in order to describe what we see, we need these two different terms. Here is another example. All of these three implants were placed subcrestally below the bone and then restored. So in this implant, we have no remodeling and no bone loss. In this implant, we have remodeling because there is no bone above the implant neck, and bone loss because we have bone resorption below the implant neck. And this implant has remodeling, but no bone loss. So that's why, in my opinion, we cannot use just one term, bone loss, for example, or bone remodeling, when we discuss implants which are placed subcrestally. When the implant is placed at the level of the bone, then there is no confusion. If you have any loss, you always have exposure of the implant neck because it's placed crestally when you have bone loss. To encourage and really to later again contradict this idea that you must have always bone loss and can call it a success, I just want to show you some clinical cases from our library which demonstrate completely the opposite reaction. What we witness a lot of time is remineralization, is when you have this initial bone remodeling and bone loss, however, with time we see remineralization. So here there is classic example of remineralization when bone with time becomes more dense. So no actual bone growth here, because there we have already vertical defect of bone loss and bone just becomes more mineralized. The same can be done also around implants without platinum switching. So here we can have delivery, and this is 5 years follow-up, and you can see by this, by the wear of porcelain, how the teeth have worn here. So this was in heavy function. This implant was really in heavy function, and you see actually bone getting better with time. Another example how different reaction of the bone can be to the implant, again depending on the implant position, still in good outcome. Here we can see subcrestally placed implant and implant placed at the supracrestal. Now, I'm not advocating that this is the correct position to place this implant like that, but look at the date. This was almost 10 years ago when we were developing our zero bone loss concepts, and sometimes we were placing implants not, how to say, according to the fashion which was at that time, but that allowed us to gather a lot of information, which later we presented to the clinicians. And after 8 years, we can see this implant with nice remodeling, and this implant actually has bone growth, if I would compare to this side. So again, there are certain conditions when they are met, you can really try to hope for this kind of outcome. Another positive reaction of the bone to the implant with time is called corticalization. And corticalization is a very good feature. When I see corticalization around implant, I'm sure that everything's gonna be okay. Because here you can see that placement of the implant, we see the cortical plate, and with time it becomes more dense and wide. Here's excellent example of the corticalization. That can happen as well. Again, not just with certain kind of implants. It can happen with different kind of implants if biological criteria are met. Here we have implant without platinum switching, 1 year follow-up, 3 years follow-up. We see a perfect, nice corticalization. And I think that implant with corticalization, it really will be stable forever. When I look at these X-rays, I have to take a breath, because during this 15 years of research, we've seen a lot. You see different cases with sometimes very positive reactions or the opposite, negative. But when I saw these X-rays, I really could not believe my eyes. Let me a little bit explain what we see here. So this is 2013, delivery of the implants. I think this is 1 year follow-up. And this is 2019. After 7 years of follow-up, now look at the bone. The implant is placed above the bone, supracrestally, because it's placed according to the design. And now look at the same implant. We see actually here almost 1 millimeter of vertical bone growth. Now, why? I don't know. Till the end, I cannot really explain you why this bone growth about 1 millimeter of both sides, But I can tell you this, that this is the case from our clinical study when we did with a vertical soft tissue thickening of soft tissue substitute. So we were placing implants without platinum switching supracrestally according to the design, and these tissues were thickened using alloderm, not some soft tissue autogenous tissues, but soft tissue substitute. The tissues were made thicker here all around, and we see that probably that creates a good environment of the bone, and we see that kind of situation. Of course, this was a good introduction, but what we sometimes see and what we want to avoid is this, that initial placement of the bone, of the implant. Now we see this initial bone loss. This is delivery. This is 1 year follow-up. So this implant actually needs to be extracted, and it just started again from a simple, small initial bone loss. And I'm sure as a clinicians, you are all aware that still we lack the methods to treat perimplantitis really that it would be stable and it would be controllable, because current outcomes, current treatment is unpredictable. That's why, in my eyes, the best prevention is best treatment is prevention. When you prevent all this bone loss, then you can really be successful. Now, zero bone loss concepts, it's not only about bone, it's also about the tissues. So here we can see 2012. Take a look at this implant supported bridge, and this is 8 years after. We see the growth, or we see the expansion of keratinized tissues. We see the ingrowth of the tissues into these black triangles. Of course, I'm not suggesting that you have papilla growth to the middle of the tooth, but look at this papilla, yeah, it's almost in the correct place. But no grafting was done here. This is zirconia restorations made according to zero bone loss concepts, and we see it a lot of times. So this is 8 years. Now look here, we have 1 year follow-up. The same story. If you would look at this situation, I think periodontists would say, okay, let's graft. Why it wasn't grafted yet? Yeah, why did they make a crown in the case where should be grafting? This is how it looks after 1 year follow-up. You see the band of keratinized tissue, which just formed by itself. Why? Because the restorative part of zero bone loss concepts is as important as surgical part. Another example. Here,
sorry, Professor.
And I would say that, of course, you need grafting over here. Professor. But sometimes we do prosthetics and then we graft afterwards in order that we already know the position of the margin. So let's say you would graft here and create keratinized tissue. After 1 year follow-up, the patient comes back like this. Now, who of us would graft this case? I think zero. Because you have everything here what you need. You have keratinized tissue. Here is, I would say, we need immobile tissue, not necessarily keratinized, not necessarily attached, immobile. Because we, in order to develop this nice adhesion, which we need that this part would not be moving. That's what we need. So this was provided here by prosthetic part of the treatment.
Professor, I interrupt you for a second. Do you hear me, Professor?
Yes, yes.
Yeah, just 2 questions for this part of the lecture.
Okay.
If you can tell us which role play the size of the prosthetic components in the development of soft tissue.
the size of the components. What do you mean? Please specify. What do you mean by the size?
If the width and the height of the healing abutment and the prosthetic abutment determine an advantage if it's narrow or if it's wider.
Okay. So this components are important, and the deeper implant is placed, the more they are important. In other words, if the implant is placed subcrestally, then I need narrow. If the implant is placed at the level of the bone, then it should not be narrow, because narrow is not to compress the bone. And of course, you need to, the profile cannot just go like this, yeah. It can go like this, but if the implant is placed at the level of the bone, then the size of components is not as important if compared to the implant placed below the bone.
All right. So one more question about this topic. Do you suggest to change the biotype of the soft tissue every time we need it before inserting the implant, or is it better to enhance the soft tissue later?
So again, the question, it's too general. We should discuss what tissues we want to change. And let me now continue with the lecture, because we will have really the answer to this question, because there are different tissues around the implants. You cannot just say I'm grafting tissues. There are vertical tissues, horizontal tissues, keratinized tissues. What do you mean? Which part you are talking about? That's very important in understanding zero bone loss concept. So can we continue?
Sure, yes.
Okay, so let's continue. And if you have a question, you again just ask it right away, because it's better to answer them right away, not in the end of the lecture. Yeah, okay?
Okay, perfect.
So what we want to avoid? First of all, we want to avoid those cases when we thought that everything is very fine and suddenly it turned out not to be like that. I call these cases closed eyes cases, because it was very easy from the beginning. So you have, again, keratinized tissues, you have wide bone, sufficient bone height, sufficient bone width. You're placing implant with platinum switching and conical connection, you know that it would not be moving. So then you can place it at the level of the bone. The sufficient stability of the implant, primary stability, allows you to make one-stage surgery. Everything heals very nice. Now you see perfect development. And now I'm making restorations. I'm making to retain restorations, because from prosthetic point of view, I think this is one of the most important things we need to choose between cement or screw retain. Here is delivery image, and this is 1 year follow-up. And if I would say just 1 year follow-up, we would say, okay, this is fine, because again, we see a little bit better boost of the tissues. You don't see the keratinized here, you already see it here. But let me show the x-rays, because if we are talking about bone stability and we are not showing x-rays, our topic is worthless. So this is the same for the lectures, for the papers. Sometimes in scientific papers, you can find the topic crestal bone loss and not a single x-ray. So don't read these papers, because you cannot really talk about tissue which you are not showing. So here you have implant placement, 2 months of the healing. We already see a little bit primary bone loss. Here is delivery x-ray, evident bone loss, and 1 year follow-up is here. Half of the implant again is out of the bone. And the most important question here is, so why? Why this perfect, easy clinical case? by selecting good implant, everything under control, suddenly turned into this nightmare when you really need to take this implant out? That's the question now we are going to discuss. To answer this question, then we must ask another question. Which factor is most important? Which factor from what we saw, which I said, caused this? You know, that's why most is in big letters. At the end of the lecture, you will understand that actually this is the wrong question. If somebody asks you this question, it means that this person does not understand the bone loss till its depth, because you cannot answer this question because it's the wrong question, but you'll see it at the end of the lecture. Of course, we need to start a little bit to, how to say, be more concrete and start to list the factors which are important. So I divide them in two big groups: implant design factors and biological factors. Let's look of these implant design features which every implant has, and how do they really influence our crestal bone stability. I think that two major implant design features are important: presence or absence of polished neck, and the microgap or connection between implant and abutment. Let's look at this a little bit more in detail. First of all, polished neck. Now, I'm not here, will tell you something new, because it's like old truth known for 30 or more years, that if you submerge the implant with polished neck below the bone, you are gonna have bone loss. And you're gonna have bone loss until the rough and smooth surface. Now, we maybe call it bone loss, a little bit softer. When people see bone loss and want to, justify themselves, they say, look, it's bone remodeling. A softer word that the bone remodeled, actually it's loss. We have lost the bone, and in case of the implants with polished neck, we are losing usually the bone till the rough surface. A lot of clinicians call it controlled resorption or controlled remodeling. Like here, the implant with polished neck is placed in the bone, too deep in my opinion. So we have this bone loss, which is called soft bone remodeling, and the bone stops in this case. Now, I'm not saying that this implant we're going to lose, but it's obvious that this implant has bone loss. And sometimes this initial bone loss or controlled resorption turns into uncontrolled resorption. Like here, you have short implant with polished neck, again placed too deep, and for some reason the bone did not stop here, it continued, and we have this implant gone. Just side by side, you have implant without any polished part, and the same patient even connected two implants together, and this implant does not have any bone loss. The start of the problem is here, when the implant with polished neck was placed too deep, and that's the problem from the beginning. That's why this implant with crown is out of the bone on the table, not because the positioning of it was too deep. And sometimes we cannot really control it. You cannot control the process of bone loss. In some cases it stops, and in some cases it doesn't. My advice here, of course, would be polished necks should stay out of the bone, and that's why we are isolating one of the factors. Another factor is a microgap, and I look at it from 2 points of view, from point of stability and from point of bacteria. The problem with microgap is this one, that if you have microgap or connection between abutment and the implant, and it's placed too deep in the bone or at the level of the bone, because of the bacteria, because of the microgap, the bone resorbs. So we have, again, bone loss below the implant neck. And all our implants are actually contaminated. The minute you're inserting implant in the bone, the inside of implant becomes contaminated. Here, similar to polished neck, we have a lot of studies which show us that you have about 1 to 2 millimeters of bone loss below the implant neck if this microgap is placed at the level of the bone or below the bone. Of course, it's not just bacteria, because as I said, connection stability or movement or how abutment is moving in the implant is connected to bacteria, because if you have bacteria inside the implant and the connection is stable, so maybe, the bacteria can stay inside and, nothing will happen. Or if the connection is not that stable, the bacteria starts to go out and we have bone loss. Here, of course, another issue we must understand that sometimes the movement itself, the movement of abutment in the implant can cause bone loss. Even without bacteria, just the movement of the abutment. That's why we must really understand what kind of connections we have. We have conus connections. Yeah, it's less mobility. You have open conus connection. It's stable, but more mobility. You have internal. Yeah, it's not stable. External, not stable. These things are important. If we would look at different designs of our conical connections, one thing we can notice that the angulation is, the more angulation, the less stability of the implant. That's why, we need to have angulation. If you want to have no movement, you need to have steep angulation like here. But here's the trick, because if I would be just thinking about implant design, this implant, as you can see here, would not have any bone loss, because this implant has no polished neck and this implant has steep, long, conical connection. So this abutment is really practically not moving. And if I would have a full bacteria inside here, the bacteria will not go out. Now, is it true that more tapered implants do not have bone loss? Well, depends. So one of the clinical cases, as you can see it here, again, wide bone, sufficient amount of the bone, 3 implants placed subcrestally according to the design of the manufacturer. We have sufficient amount of keratinized tissue, so this part is not moving, so we cannot say that there's something wrong with the tissues. And suddenly we see that this ideally designed implant placed in ideally biological situation has bone loss. And this is not 10 years follow-up. This is one just delivery X-ray. You see bone loss even before the loading, because already you have healing abutments and bone loss. What I wanted to say, that implant design factors mean nothing, because it's just how the implant is made. So implant design factors start to mean something when the implant is placed in the context. And context is our biology. When the implant is placed in the bone in different amount of the tissues, then our features become important. You just cannot say that in vitro test, if the abutment is not moving, so it's the best. That's the wrong way to do it. That's the wrong way to look at these situations. And apparently this case shows us that there is something more, not just implant design factors. There is something more we need to look at, and that something more is called biology. What biological factors are important? And here we go to the question, the second question, which was asked: do we need to change biology in every time we're placing the implant? Well, my answer would be, what kind of biology, what kind of soft tissues we are talking about? Because you can have keratinized or attached tissues, you can have horizontal tissues, you can have biotype of the tissues, and you can also have vertical soft tissue thickness or crestal soft tissue thickness. So this vertical tissue thickness has been forgotten for many years, and maybe those are tissues who are responsible for this commonly not explained bone loss. To be more precise and that we would understand a little bit better, I put all those parameters in one slide. So you have vertical tissue thickness, you have horizontal tissue thickness, and you have attached tissues. So attached tissues and vertical tissue thickness are similar factors because they both have this vertical component. However, attached tissues are different because, you know, they are just measured in different positions. Now, from this part, these are different parts and they play different role in our implant success. So when people say, should I augment the tissues? I'm asking, what tissues you have in mind? Do you want to augment here? Do you want to augment here or here? Or maybe to augment everything right away? That's also possible, but you need to be more specific. Now, why do we need this vertical tissue thickness, this part? Because from that part, you have development of biological width. Only from that. Attached tissues, keratinized tissues, play zero role in development of biological width. And biological width is our protection of the implants. Because that's the only protection we have from bacteria. That's why this vertical part is so important. Well, I could tell you like 1,000 times. Biological width, vertical soft tissue thickness is important for protection of the implant. Vertical soft tissue thickness is important for protection of the implant. And we have in Lithuania one saying, which says that it's better to see once than to hear 1,000 times. Now I'm going to show you a video. It's a very nice video, which in my opinion, when I saw it first, when my colleague has shown me, it really put everything together. So probably it will happen to you as well. First of all, we all know that our vertical tissues are divided in two zones. You have adherence zone, or the zone when you have the protection, when the tissues contact to the surface of abutment, and you have plaque zone or contaminated zone. So actually the perimplantitis is increasing of plaque zone and increasing of adherence zone when the plaque is coming closer to the bone, and you have perimplantitis. Now here we have a situation when we place the implant did not integrate, and when we refined it out of the bone, you see still certain amount of the tissues were left adhering to the multi-unit abutment, which was connecting during the time of the surgery. So we unscrewed the abutment to see what will happen. So this is what happened. Do you see what happened? Do you see the difference in cleanness of the place when there was soft tissue adherence and no soft tissue adherence? So here you have your adherence zone and you have plaque zone. And if you don't have sufficient amount of the vertical tissues, so this zone will be always small. That's why the plaque will be closer, and then you're going to have this initial bone loss. Now, if the zone is higher, then you have the possibility to develop better biological width. And that video is also nice because it really shows you the connection between surgery and implants, because how the tissues will adhere also depends on the material of this abutment. Is it titanium? Is it zirconium? Is it smooth? Is it polished? So that's, as I say, that's the prosthetic part of zero bone loss concepts, and they are also important as well. Thus, we have two different scenarios. So we can have different kind of situations: thin tissues and thick tissues. Maybe if we're placing implant in this kind of environment, vertically thin tissues, maybe that's you're having this bone loss, and just by solving it, you could have better outcome. Or in other words, if you have thick tissues, maybe that's enough to get bone stability. Well, when people, I've been challenged many times, and that's completely fine, I like, when people start to say that, maybe, soft tissue thickness is not important, I say, you are not arguing with me. You're arguing with Berglund and Linde, because they were the first, the fathers of modern implantology, modern soft tissue thickness, soft tissues around implants, per-implant tissues, creators. They were actually the first to answer this question, because I found this study when I was looking 15 years ago, and what they did, they get the dogs with thick tissues, about 4 millimeters. In part of the dogs, they thinned the tissues to 2 millimeters, and then they followed up these animals. And in control group, with no thinning of the tissues, they had no bone loss. While here they had, in thin tissues, 2 millimeters or less, they had 1.3 millimeters of bone loss. So that's was known already in 1996, quite time, 30 years ago. And they made the conclusion that thin tissues can cause bone loss. What was the problem with this paper? Only one. It was an animal study. You cannot just take animal study and put it in a clinical environment. So that's when our group stepped in, and in 2000, from 2005, we started our clinical research. I wanted to see, does this theory really work? So is soft tissue thickness, vertical soft tissue thickness, an important factor in crestal bone stability? To achieve this goal, we designed a study when we put implants without platform switching and polished neck, no conical connection, supracrestally. Why? Because we isolated microgap and polished neck. Again, I'm not saying that these implants, should be placed like this now, but this was a part of the study which we did 15 years ago, and that study gave us a lot of information. And then we measured vertical tissue thickness over this implant. So in this implant, all other implant design factors were isolated. Only vertical soft tissue thickness was different. We measured, of course, the width of the bone, the height of the bone, the keratinized tissue. So all these aspects were included in inclusion criteria. And the outcome was actually the same as in Berglund and Linde study. The numbers are probably also the same, because in thin tissues, we had 1.35 millimeters of bone loss. And in thick tissues, we had almost no bone loss, 0.25 millimeters of bone loss after 1 year. We published it already now 11 years ago, 2009. So this information is old, 10 years in research, it's old. So it's nothing new, it's just, it somehow does not reach us as clinicians. We tend to forget that measuring of vertical tissue thickness is as important as measuring the width of the bone. What I like about clinical research is, of course, possibility to follow up patients for many years. This is the patient from that original clinical study. So we have the placement of the implant. Now look at this. So this is supracrestal implant placement. This is 1 year follow-up. This is 13 years follow-up, 13 years follow-up of the implants. Now look at the bone. The bone is vertically growing. Why? I don't know. But one of the reasons I can tell you for sure that vertical soft tissues, because this goes from the thick tissue biotype group, thick vertical tissues has good influence on crestal bone behavior. What about platform switching? Because, yes?
Professor, sorry, I will stop here because we have two questions. So considering the main issue about biology, we want to know if Dr. Fabio Manuel Finalnino is asking if we are in need to enhance the vertical soft tissue, what would you do? I mean, do you prefer to choose a narrower component, or do you prefer to enhance the soft tissue with a graft or whatever?
Narrow component does not change, does not thicken the tissues. You need to change to enhance the tissue volume. There are four ways how to do that. You know, you can, we'll talk about it a little bit later, but just if you have thin tissues and do nothing, nothing will help you. It's mechanical thinking. You know, we change something with the implant, we change something with the abutment, and we think that the tissues will become thicker. No, vertically, you need vertical enhancement. Maybe with pattern switching, you can have a little bit more horizontally, but for biological width, you need vertical because it doesn't, how to say, distance bacteria more. Yeah, it just stays at the top of the tissues. Hey, sound, you can.
The vertical part for you is the most important. Then
no, that's the wrong question. Wrong question. Okay. There is no most important. It's
all right.
It's important. It's important, yeah. And when you start to think that everything's important, but everything is controllable because it is controllable, that's your pathway to no bone loss.
Okay.
Okay.
So one more question from Dr. Giuseppe Ramundo, that he's a fan of yours. Okay. And he wants to know if one abutment one time is very important to reduce marginal bone loss.
I would answer it like this, similar to components, depends on the position of the implant. When the implant is placed subcrestally, below the bone, let's say 1-2 millimeters, then one abutment one time is very important, because we just finished research with using connect abutment from MIS company, and it's not published, it's not written, but already it's in the process. But we found that with subcrestal implants, the less disconnections you have, the more bone becomes stable. Now, if the implant is placed at the level of the bone, yeah, and there is no bone above the implant neck, then I think one abutment one time is not this crucial thing. I mean, you can disconnect, you maybe will have certain bone loss in the beginning, but it will come back. You will have remineralization.
Right. All right. Thank you.
Good. Now let's then continue with the lecture. So we stopped here when we said that implants, when you have thin tissues 2 millimeters or less, you are going to have bone loss. But what about platinum switching? Because platinum switching is known a very good feature of the implant, design feature, which really, in majority of the cases, in clinical studies and systematic reviews, came with the conclusion that implants with platinum switching do better preserve crestal bone compared to implants without platinum switching. However, you know what we see sometimes, that with you can have bone loss with platinum switching implants, And again, different reaction. You can have no bone loss with implants without platinum switching. Now, when we start to think about biology and implant design as a one, you can explain this easily. Because in these pictures, we see that implant without platinum switching is better compared to implant with platinum switching. But here you can see that implant is placed above the bone according to the design, but look at the tissue thickness. Tissues are thick, and then everything depends on implant design. Implant is placed correctly. Now, implant with platinum switching, conical connection, how to say, technically more advanced than this implant, but look at the tissues. That's the idea. You cannot say which factor is important. Which factor is the most important here? If you ask the question, you cannot answer. Everything's important. This is important. This is important. But here, if this factor is not satisfied, then you really will lose bone. And when I looked at all these studies which talked about vertical tissue thickness, which talked about platinum switching implants, none of them, 0 studies, measured tissue thickness. So it means that majority of those studies were missing one of the crucial components, vertical tissue thickness measurement. To solve this, we have done series of clinical studies when we compared implants with platinum switching in thin tissues and in thick tissues. I'm just gonna show one of them. Here we used Straumann bone level implants. In thin group, we were placing them at the level of the bone and one-stage surgery. And in thick group as well, the same procedures. 2 months of the healing to the implant would integrate and soft tissues would form, and then screw retained restoration was delivered to the implants in order to reduce semen remnants. And that is the outcome of the thin group. You see placement, 2 months of the healing, restoration, and 1 year follow-up. You can see bone loss about 1.2 millimeters. And in thick group, with thick tissues, we were used to see what the picture was, what we were used to see around implants with platinum switching. Here I'm gonna stop a little bit because there's always a concern and question about, do we need wide abutment? Do we need, is the height of thigh base important? Now look at these X-rays. So this study was started 2010 or 11. At that time, Straumann did not have any barrier base. So we were using provisional cylinders as thigh bases. All of them have probably less than 1 millimeter, and you can see quite wide. And these implants did not really have bone loss because they were placed at the level of the bone. And in this case, you have thick tissues. So when you have position of the implant at the level of the bone, then the height of your thigh base is less important if you would compare it to the implant below the bone. And we have published this already 2013 in the paper. This is, again, was one of the first paper to show that in thin tissues, 2 millimeters or less, platinum switching is not as effective as we have thought. Currently, we have, I think now, over more than 8 or more publications concerning vertical soft tissue thickness and its influence on crestal bone stability. Of course, it is good that there are other teams in the world which follow the same principle and do research on vertical tissue thickness. And the group from Belgium, Verwerke, has published research actually giving the same outcome. And this is another paper of Belgian group, a very important paper. Actually, I want to stop on it a little bit more, because this is one of this is the first, how to say, scientific proof of one of ways to increase vertical tissue thickness by placing implants subcrestally. So they had two implants, crestal and subcrestal. So after the 2 years, they had bone loss around crestally placed implant in thin tissues, and a subcrestally placed implant had much less bone loss. And certain amount of other papers, which let's not dive into them, which confirm the idea that vertical tissue thickness is important factor. Well, so for the last part of the lecture, let's define then what is this exact minimal tissue thickness? What is the number? So we always need the number, because when I say thick or thin, we need to have numbers in order to understand that. In the studies, we have used 2 millimeters as the threshold. Now, why 2 millimeters? Because we just took what was available, and at that time, the animal study from Berlin and Linde, they used also 2 millimeters as a threshold. If that would be so 2.5 millimeters already would be thick tissues. Yeah, so it's thicker than 2 millimeters. And so we should not have bone loss around implants if they are placed with 2.5 millimeters of tissue thickness. That is why 5 years ago, we decided to do another clinical study when we had 3 different groups. So we had tissues of 2 millimeters, 2.5, and 3 millimeters or more. We wanted to test what will happen with the implants if they are placed in medium tissue thickness. Of course, we needed a different kind of probe to have it 0.5, because of course we cannot measure 2.5 tissue thickness with 1 millimeter probe. You need 0.5. And we had 3 different groups. Again, the same amount of implant. Inclusion criteria allowed us to include only thick bone, because that other factors would be neutralized, keratinized tissues. Everything was done as it should be. Results showed us clear correlation that when soft tissue thickness is increasing, then bone loss is decreasing. So that's one. Another lesson was that 2.5 should not be considered as sufficient amount of tissue thickness, although by the old threshold, it would be already more than 2. It means thick, because we had about 1 millimeter of bone loss around 2.5 millimeter tissue thickness. Everything comes to logical conclusion when we look at this graph, because there was no statistical difference between thin tissues and medium tissues, between 2 or 2.5 vertical tissue thickness. That's why we are saying that you need to move our threshold to 3 millimeters of vertical tissue thickness. Not 2, but 3 millimeters is the minimal amount. Now, when we talk about 4, I think 4 is optimal, because 3, it's to avoid, but then with 4 millimeters, you can really also have possibility to develop soft tissue profile. Why I'm so sure that 4 millimeters is okay? Because there are a lot of studies, for example, this one, a histological study from Cristiano Tomasi. He measured all the height of the tissues with implants without bone loss, and they found 3.6 millimeters. If we would look just at the original, these are original drawings from the Berlin and Linde study, the control group was not just above 2 millimeters, the control group was about 4 millimeters. So they just thinned the tissues into 2. And that's why they say that 2 millimeters is new threshold. Actually, they did not have bone loss when the tissue thickness was 3.65. I consider then that 4 millimeters is actually optimum amount, and 5 millimeters would be the maximum. So 3, 4, 5, these numbers I'm using in my daily practice in order to control vertical tissue thickness. Well, then the logical question would be, so what do? We have thin tissues. Because tissues are important, what's our strategies? 2015, already 5 years ago, me and my colleague, Algirdas Puišys, we created the algorithm, how to work, how to augment tissues in 4 different ways, depending on your implant design, depending on how you need to work. So you have a lot of ways to increase soft tissue thickness by flattening of the bone. You can do subcrestal implant placement, 10-pole technique, vertical augmentation, but all of them are connected to biology. You are not modifying implant because it's mechanical understanding and it won't help you. You need to change biology, change this biological type. If I would go back again to the question which I asked in the beginning, which factor is most important? So the question is, the answer is that it's the wrong question. We should be asking ourselves how factors relate to each other. And since we start to do that, then we can really have the normal conversation and discussion and understanding. Because how implant is placed is important. Is it crestally, is it supracrestally or subcrestally? This is implant without platinum switching. Tissue level implants, you can place them differently. That's influences your crestal bone stability. The same with implants with platinum switching and conical connection. Doesn't matter how good the connection is, if tissues are thin, you will have bone loss. But if you maybe submerge the implant deeper, like here, maybe you are creating yourself a better solution. So these are different questions, of course, which are also part of zero bone loss concepts, and we answer them in different lectures, in courses or online courses. But I want to finish before I show some team home messages, also show this analogy. So I consider crestal bone stability like a basket of apples. Each apple represents a separate factor. What we do in research you cannot just evaluate all of them because you will have too much confounding factors. That's why you take out apple of the basket and research it separately. What do I mean take out? Take out meaning isolating other factors. For example, that's what we did with the first study when we were placing implants supracrestally, because we isolated microgap, we isolated polished neck, all implants had white bone, so everything was isolated. And when we found that this is important, what we do, we are putting the apple back, because tissue thickness is as important as polished neck, is as important as conical connection, is as important as platinum switching. When you understand this, then it's the way to work. Now, of course, I want also to make some comments on this unique situation which we're having now, because, you know, like today is the first day officially we can work in Lithuania and treat the patients. So for 2 months it was lockdown, but of course it will impact the way we communicate and make education. And for example, our webinar is just an example. I think it's a really cool example because I think in time we're going to do it more, but actually the courses was our like normal way of communicating, yeah, and giving that. So in order really to change this a little bit, I put all the zero bone loss concept knowledge into online course. So all things which we are discussing now and all the solutions and everything, what I teach in normal 2 days course, it is in online course. So you have 12 lectures. And the lectures are, you know, not just I'm standing by the screen, you know, they are attractive, they are with animations, they are interactive, and I think it's a really nice way. One thing I want to mention that, of course, you might say that, you know, we lose the direct contact, but we designed the possibility to ask the question. So just like you ask it now. So you type the question, for example, and I receive the question and I answer it. Of course, not right away, but, you know, the next day I'm having the question and I can answer it as well. So in my opinion, it's really informative and really, really nice. So I want to finish up with these 4 take-home messages. Vertical soft tissue thickness is a separate factor, as important as, let's say, width of the bone. So we always measure width of the bone before implant placement, yeah? Somehow we do not question this. So the same should be done with vertical tissue thickness. You must know the exact number before implant placement. 3, 4, 5, 3 minimum, 4 optimum, 5 maximum tissue thickness. Keratinized tissues, of course, should be present as another biological factor. And crestal bone stability is multifactorial issue. And when we understand this, that's the way to zero bone loss around our implants. Thank you for your nice attention. And so if you have any questions now, let's hear them.
Thank you, Professor. Yes, we have two more questions about the biology. The first one I think you answered already, but anyway, which is of the 4 methods of vertical soft tissue augmentation, which is the one that you prefer the most?
It's depending on the implant. So if I'm placing implant with platform switching conical connection and I have available bone, I submerge the implant. Now, if I'm using tissue level, I cannot submerge it, yeah, because I will solve one problem, yeah, I will increase tissue thickness, but I will create another because we'll have bone resorption because of polished neck. So let's say with tissue level implants, we do vertical augmentation with the grafts. So that's the idea that, you know, you can adapt each of the methods according to your implant you have, according to your philosophy, according to what you really believe in.
Right. And another question from Dr. Ramundo, which is in your opinion the biological impact on marginal bone resorption with the use of convergent abutment or convergent collar?
Converging, what do you mean by that?
Convergent abutment, like the bio-TP technique applied to the abutment.
Yeah. Okay. So yes, understood.
What about the collars also? Because we have also implants designed with the convergent final part.
Yeah. So narrow abutment. I know this technique, and in that technique, implant is placed always subcrestally. So that explains. I mean, as I said, in subcrestal implant placement, you need narrow abutments because you will in our way, you will be pressing the bone. So it's not, in my opinion, the matter of narrow abutment. It's also the matter of position of the implant. So when you combine these two things, subcrestal implant placement and narrow abutment, that's why you have a successful bone stability. Now, if you would place the same implant at the level of the bone in thin tissues and put a narrow abutment, would that work? No, because it's not mechanical issue. I mean, as I said, we should stop looking at it that something like modification of your implant would act miracle biology. No, it's combination of different things. Now, and what the color is concerned, I don't know. Could be probably a very interesting topic to look. Does anodization really have any influence of soft tissue attachment or, yeah, but in our concept, we did not really look at it.
It would be another step of your research work.
Yeah, it could be. Now, then you could really need to, again, do everything the same, and then just one implant should have like anodized color and the other should have not anodized. So it's possible to do, of course. Yeah.
Okay, we have a question from our president, Dr. Rossi.
Yes. Thank you, Professor Linkevicius, for your outstanding webinar lecture. I'm really happy to have you on our virtual stage this evening. I have just a little question, but not about hard tissue, soft tissue, but about this moment, the COVID-19 in Lithuania. What about the situation in Lithuania, in Italy? From 2-3 weeks, we are going back to our clinics, dressing particular clothes, face mask, and particular management of our patient during, after, and before our treatment. So what about in Lithuania, similar or different from the Italian situation?
Yeah, so as I said, today is the first day we can work and plan surgeries, not just emergencies like before.
Okay.
We have to, our government has issued some restrictions. Some of them say that you need to reduce the flow of the patient, that the patients would not, you should not have, let's say, there is a limited amount of patients can be in the waiting room. The better that they would not meet at all. Let's say you check one patient, you get and that one. So that's one. Then according to the clothes, you need to have, we have different like levels of security. So we have the third level. It means, I don't know, is it the same in Italy, but we need to have this gown, which is not soluble. You cannot, the water cannot penetrate it.
Yes.
Then you have to have this mask respirator, the mask of forehead cap. Then you have to have this shield, and then you have the gloves, and that's it.
The situation is similar as the Italian situation. So
yeah, but for example, in Germany, some of friends, they called me, they work the same. I mean, they work like before without any increased security. So I don't know, because it's really difficult to work. It's not, it's not normal work. I mean, you can.
It's not so easy. It's not so easy to.
Yeah, I think that you can forget about precise work, at least in the beginning, till you get used to it. I mean, because you feel not comfortable, you cannot concentrate, let's say, of doing, some precision something, because it's hot, it's bulky. So it's, let's hope it will pass. Yeah.
Okay. Thank you again. Thank you, Leone. And thank you, everybody.
Thank you very much, Professor.
I hope that we can meet in another event, another situation, maybe a congress around the world, and not on Facebook.
Yeah.
And, stay with us for everybody, and stay tuned with our page, and for the other webinars or lecture like to this evening. Okay.
Good. Thank you. Okay.
Bye. Thank
you all.
I'm glad we did it. Okay. Bye-bye.
Bye-bye.
Bye.